Today we have two excellent presentations for you. One is on state-of-the-art of pathologic fractures, and this will be given by Dr. Susan Bucata from Rochester, New York. Dr. Bucata is a tumor surgeon, and this is her primary area of practice, as well as metabolic bone.
Thank you very much. With the growing silver tsunami that is approaching us with geriatric patients, as well as the fact that more patients are living for a long time after their primary cancer and with their primary cancer spread to other portions of their body, almost all orthopedic surgeons are going to see a pathologic fracture or a lesion in bone that's due to a malignancy. Sometimes these can present in very unexpected ways. Here's a recent case that presented to our university, where a 77-year-old female with known osteoporosis fell and experienced increasing right hip pain. And here we can see a relatively standard intertrochanteric fracture of the right hip. On lateral views, nothing is very exciting. However, we require our residents to get full femur films of all fractures in AP and lateral views. And when you extend the film down, you can see a lesion further down in the diaphysis on both the AP and the lateral view. This patient did not have any known primary cancer. However, if you got her history, she was admitted with 2 months of increasing thigh pain, including night pain, both of which are symptoms that are concerning for malignancy. In the United States, more than 30% of US citizens will develop cancer at some point in their lifetime, and it accounts for almost 25% of deaths in the United States. 2/3 of these cancer deaths occur in the geriatric population in patients over age 65. The most common non-skin cancers that present to bone are prostate, breast, and lung. If you see a patient with a lesion in bone who is over age 40, your first thought should be metastatic disease. Also, it should be at the top of the list of anyone who has a known prior malignancy. The 5 most common malignancies that go to bone are things we recognize: lung, breast, prostate, thyroid, and renal cell. Less common tumors also can metastasize to bone: melanoma, non-Hodgkin's lymphoma, laryngeal carcinoma, esophageal cancer, bladder cancer, Hodgkin's lymphoma, and colorectal cancers also can commonly present in bone. Sometimes the initial presentation of these cancers can be in the bone. The most common locations for metastasis are where your body makes bone marrow: the spine, the iliac wing of the pelvis, the ribs, the skull, but also the proximal long bones, particularly the proximal femur and the proximal humerus. The morbidity of bone metastases is quite significant. It is the 3rd most common site for metastatic disease from almost all cancers, and 50% of all cancer patients will experience a bone and skeletally related event due to their cancer. These may be pathologic fracture, immobility, can have significant bone pain, paralysis, hypercalcemia, and a significant impairment to quality of life. Patients with breast cancer, almost 80% of breast cancer patients will have a skeletally related event during the course of their cancer. So the therapeutic goals for pathologic fractures and for patients with bone lesions are to prevent fractures, to relieve pain, to restore and maintain mobility, improve quality of life, improve survival, and then if possible, prevent further metastases from occurring. There are 3 main types of lesions that occur in bone. Lytic lesions is what we recognize most easily. These are commonly found in lung and renal cell and are at highest risk for fracture. Breast cancer and prostate cancer often present with blastic lesions. These are very painful. They seem to cause pressure in the bone and often are associated with night pain. Although these also increase the risk for fracture because the bone is disordered, it is still more dense than a lytic lesion where you've basically carved a hole in the bone. That makes these lesions less likely to fracture than a lytic lesion. Most lesions that present, however, are mixed, and here you have a combination of blastic bone and lytic bone together. It is often unsafe to assume that any given skeletal lesion is necessarily related to a proven carcinoma. There are many patients who present with multiple primaries, The combination of breast cancer or prostate cancer with lung cancer is very common. Many of those patients were lifelong smokers, and they are at significant risk for lung cancer. There are also certain genetic abnormalities that make people susceptible to multiple primaries. It is sometimes not uncommon for us to see patients who present with things like multiple myeloma, as well as diseases like breast cancer and prostate cancer at the same time. So what do we do with a patient like this that presents to your emergency room? Here we have a 63-year-old female who has no history of cancer. She's had 5 months of knee pain, but she's obese and known to have arthritis. She's gone through pool therapy and rehabilitation. She's been on non-steroidals, but the pain is unrelenting and is beginning to become more common at night. But again, arthritic pain can occur at night. She suddenly felt a snap and presented to our emergency room. So there are several different scenarios when thinking about these patients. First, you may have the patient who has known cancer and multiple bone lesions. In that situation, you want to biopsy the fracture site if another lesion has not already been biopsied. If another lesion has not been biopsied and it's the first time they're presenting with multiple lesions, you should obtain frozen section in the operating room before proceeding with surgery, because it is still possible for sarcoma to present that way. You should get fractured tissue regardless of the pathology and regardless of whether it has been biopsied before, just to confirm that it is indeed the same primary tumor as other lesions that have been recognized and diagnosed. You may also get the known cancer patient with a single bone lesion. It is extremely important in this patient to biopsy the lesion before you put in hardware. This may mean delaying surgery. However, primary sarcomas can present this way in bone, and it is extremely important to know exactly what you're dealing with before you place your hardware. It may not only change your surgery, it may dramatically change the course of treatment for that patient. There are times when chemotherapy or radiation or things such as embolization are needed prior to surgery in order to make it safest for the patient. You may also get a patient without a history of cancer who presents with multiple bone lesion. There you want to biopsy the most accessible site, even if it isn't your fracture site. Most commonly with a pathologic fracture, the fracture is the most accessible because we will be making surgical incisions. And then finally, you may get a patient without a history of cancer and a single bone lesion. Again, it's extremely important in that patient, particularly, to get a biopsy and have your pathologist be fully confident about their diagnosis before you place hardware. There are several tools that are very helpful for biopsy that are available in almost every operating room. This is a Jamashidi needle, which is used for bone biopsy. It's an 11-gauge needle, has a central core. It's very good passing through cortex, passing through trabecular bone, and you have a tremendous amount of control over the direction of the needle. You need to remember to remove the inner liner of the needle. There's a needle in the central portion of this, and then it becomes hollow core. You get your specimen in the hollow core section, so it's important to remove the inner liner before you advance it through the tumor or the area of bone of interest. You need a non-Lurlock syringe to connect to the top, and we always teach our residents you have to wiggle and twist and then suck back before you pull your specimen. This allows the specimen to be separated from the adjacent tissue. Many times the specimen gets sucked into the syringe, so when you bring it back, if you put the needle back in to try to push out your specimen, if it's not there, look in your syringe. It's often on the black rubber in the syringe. These tools are also very helpful. Certainly you can use pituitary rongeur and you can use standard curettes. However, these are endometrial curettes and uterine curettes. They're available again in almost every hospital. They're about 15 inches long. So they become very helpful when you have to reach, particularly down a diaphysis of a bone. The one on the left is the Kevorkian, and then on the right is the Heaney curette. Here you can see a case where we have a lesion in the peritrochanteric area of the hip, and through a standard approach for a trochanteric nail, we're able to reach into the diaphysis and get good, clean scrapings of the tumor to send for pathology. This can be very helpful in the setting of frozen section, because it is often difficult for the pathologist to make a diagnosis on reamed material. The reaming burns the material, it also crushes the bone, and it can make it difficult to get good histologic slides, and also if special staining needs to be done in order to determine the primary tumor, it can make it very difficult to do with that tissue. Pathologists will encourage all orthopedic surgeons to try to get a primary specimen prior to reaming in order to give the best chance of doing full histologic studies that will be most meaningful. Another helpful hint when you're doing a nail, the standard tube soft tissue protector that we use for most trochanteric nails, when you bring back your reamings, every once in a while pull back that tube and dump the reamings into your hand. Your best specimens are often contained within that tube. They don't always come out with the reamer. So often you'll have more material in that soft tissue protection tube than you will on the actual reamer itself. So in summary, in management of patients such as this, we need to do a needle biopsy or open biopsy at the fracture site to confirm our diagnosis. Do a frozen section intraoperatively if your institution allows that. If it doesn't, it is worth in these patients waiting to put in the definitive hardware until you know exactly what you're dealing with. It can make a significant difference in your surgery, particularly if this is a sarcoma. If it is a highly bloody tumor, such as a renal cell, it gives you the opportunity to have embolization, and it allows you to plan the appropriate hardware device that you need for this patient. In general, we try to stick to the one bone, one surgery, if possible. In this particular patient, it would have been ideal to do a retrograde femoral nail. Unfortunately, she had so much bone loss at her lower diaphysis that it really was not possible to do a retrograde nail without shortening her significantly. Because we opened at the fracture site, we opted for locking plate and for cement. But certainly a retrograde nail with less bone loss, and even opening to add cement around that retrograde nail would be a good choice. We use long locking plates with bicortical screws, and we use two static bicortical distal locking screws on lower extremity nails. Many times in trauma, we just lock with one distal screw. In oncology patients, you have to realize when they leave the operating room, this is the best they're ever going to be. And there's a high likelihood that they will not only not heal, that more bone will be destroyed, and that other lesions will appear proximal and distal to the lesions that they currently have. So it's not uncommon for one of the distal locking screws to become unsecured during the course of disease progression. You also have to do post-fracture modification. The goal with these patients is to get them weight-bearing as tolerated immediately. So an evaluation strategy for these patients, if they have skeletal metastases of unknown origin, not a known primary, you need to take a good medical history, do a physical exam. Breast exam is avoided by our residents at all costs. However, that's one of the major presenting cancers for women in the United States. So it is important with an unknown primary to take a good look at the patient's skin, to examine the breast if necessary, to get whatever history you can from the primary care, and to talk to the patient. They will often tell you that there has been a problem mounting, and they'll help key you into what has been going on. You want to do a good physical exam. You want to get x-rays of the chest, PA and lateral, as well as full x-rays of the entire bone that's involved in AP and lateral views. You get a whole body bone scan, which will help you to find lesions across the entire body, and a CT scan of the chest, abdomen, and pelvis. 85% of tumors are identified with this strategy. It allowed us to localize the primary tumor. So what do you do about the impending pathologic fracture? The Morell's criteria is what we use currently. If the patient gets a score of 10 or higher, they're very likely to fracture and should undergo prophylactic fixation. If they have a score of 7 or lower, they are unlikely to fracture. In the 8 and 9 category, we have to use physician judgment based upon the overall presentation of the patient, the degree of pain, and the location of the tumor. One thing of note, if you use this criteria, if you have a patient who has a peritrochanteric lesion that's lytic and is causing pain for them, that automatically scores them as a 10. You do not even have to remember the scoring system. That patient is at very high risk for fracture, and that's the majority of lesions that we do fix. Older guides sometimes are easier to remember and work almost as well. The Harrington criteria from the early 1970s show that if there's greater than 50% cortical erosion in both the AP and the lateral view, the lesion's greater than 3 centimeters, it's lytic, it's in a weight-bearing bone and causes weight-bearing pain, or it causes a longitudinal complete defect in the cortex that's greater than 3/4 of the diameter of the bone, that bone is highly likely to break and should undergo stabilization. The basic principles with these patients, you want stable fixation. Use this internal fixation device. We use rods very commonly. We use locked plates. Use the principles like we use in the geriatric patients. getting bicortical fixation, going long with your plates, making sure that you have good stability, even if you have to shorten the limb in order to obtain that stability. Around joints, we often have to use a prosthetic device as replacement. Use cement if necessary. Get that patient up and mobilized as quickly as possible. Post-operative irradiation is certainly required, and you need to try to avoid complication, including infection, hemorrhage, hypercalcemia, and disease progression. Radiation is absolutely essential in these patients in order to prevent local recurrence of the disease and continued damage. You have to irradiate the entire area that was surgically approached. So with a nail, that means the entire bone. If you do not radiate, you have a 15 to 20% chance of recurrence locally at that limb. If you do radiate, that drops it down to 3 to 5%. Even though that doesn't drop it down completely to zero, it often buys time for you to allow that patient to have a stable limb that doesn't give them a problem while they are still alive from their disease. One helpful hint, we often close with staples. The problem with staples when you're simming for radiation, whereas we know with MRI, in MRI you cannot place the patient in the MRI if they have staples on the skin. In radiation, the staples create an echo at the skin, and that changes the measurements in terms of the strength that they need to penetrate the skin. If you close with a simple nylon in a running baseball style fashion, those sutures not only can remain in for an incredibly long period of time, you can vary the size based upon the quality of the skin for the patient, but it also does not create problems with the simulation for radiation. Bisphosphonates are now used commonly in patients who have skeletal related events. They decrease the rate of pathologic fracture, and they may in fact have an effect on the tumor itself. In breast cancer patients who are treated on bisphosphonates, they have improved survival and longer time between skeletally related events. Even patients with breast cancer who do not have metastatic disease at the time that they present, but who are placed on oral bisphosphonates to prevent osteoporosis associated with their chemotherapy, have better long-term survival and fewer skeletally related events. TGF-beta is a common growth factor in bone, and cancer can liberate this, and particularly breast cancer really grows well with TGF-beta, so this may be one reason why bisphosphonates can help with the cancer itself. Iridia, which is pamidronate, given in 90 milligram dose, is often used in the United States as the initial dose because it's available as a generic and very inexpensive. It can be used in patients with some renal function problems. It can be dose adjusted based upon creatinine clearance, and I encourage you to have your medical oncologist in the hospital make this decision and adjust dose accordingly. On the outpatient setting in the United States, zoledronic acid, which is Zometa, at 4 milligram dose is most commonly used, and with most chemo protocols, it's given every 4 to 6 weeks. One of the new areas that's entering oncology is rank ligand inhibition, denosumab, and for cancer in the United States, it'll be called Exjava. 120 milligram subcutaneous dose that's given monthly. That's different than Prolia, which is 60 milligrams given subcutaneously twice a year for osteoporosis, although it's the same drug. Here, this acts as a decoy receptor for the rank ligand signal and suppresses osteoclast recruitment, development, and function. Clinical trials showed it to be non-inferior to zoledronic acid, and you do not have to make any dose adjustment based on renal function. It is just recently approved in the United States, but not currently available. Approval in the UK as well as in Europe is still pending. So conclusions from all of this: biopsy and confirmation of the tumor type is important even if it delays the surgery. This is very different than the way we think about most trauma, but is extremely important in dealing with the patient who has a pathologic fracture. Immediate weight bearing is tolerated is the goal, even if it means you have to shorten the limb in order to get stability. Postoperative radiation is essential, and you want to get the patient engaged as quickly as possible with medical oncology care. They can be placed on bisphosphonates. Also, chemotherapy decisions and decisions about further treatment can be made. So, thank you very much.
So, Dr. Bucata, we do have some questions, and we have a question from Dr. Ramirez in Chile. He would like to know how long the nail or plate should be with this type of pathologic fracture. Should it cover the complete diaphysis or just a portion of it?
In general, we try to go the entire length of the bone, and in oncology, we put in very long nails. Often we'll have the tip of the nail be in the femur, approximately the level of the top half of the patella. We'll place our guide wire, 2 Blumensax line to the epiphyseal line, and then put in as long a nail as we possibly can get. You do have to make a judgment so that you place your hip screw in the correct position. However, try to put in as long a nail as possible. In the humerus, we go all the way to the olecranon fossa, and occasionally we put the tip of the ball tip guide wire into the fossa and then place as long a nail as possible.
Do we have any questions from the local audience here in Davos?
So the timing of radiation after surgery in general is about 14 to 21 days following. That is about as fast as you can get the skin incisions to heal. And you want to be almost at the point where you're comfortable taking your sutures out. If you're not sure, it's perfectly fine to start radiation with the sutures still in. However, you certainly don't want to have an obvious open wound or weeping wound. And some of these patients have already been on chemotherapy or on significant steroids, which can slow down their healing. Do we use chemotherapy preoperatively if we know the tumor? Sometimes we do. In myeloma, some patients actually have such significant renal impairment that they really are not safe for surgery. We'll do what we need to stabilize the fracture in the best way we can, often with braces, get them in a better medical position, and then treat them surgically. Often, especially if they've had a fracture rather than just an impending fracture, we have to be much more aggressive because the complications after an actual pathologic fracture are much greater. It's easier to slow the patient down with an impending fracture than it is to prevent a patient who has a real fracture from having problems with pain and skin breakdown.
So we have a question from the Netherlands. Dr. Sturkenboom asks, how do you handle the dilemma of puncture sites spreading tumor cells when performing a needle biopsy in the case of an unknown primary, especially like a sarcoma lesion?
So that's a very good question, particularly when you think about primary sarcoma, particularly chondrosarcoma. The blue marking pens that we use in our operating room, you can take the felt out, and we will often stick that in our biopsy tract. That'll keep the tract dyed for approximately 30 days, particularly in skin on the leg, which doesn't turn over as frequently, and allows us to find the biopsy site. So at the time of primary resection, we can remove the biopsy site as well. Overall, needle biopsy has become the standard of care in oncology for sarcoma, and many times that tract is not marked for us. We do look for it at the time of resection, and we try to mark it as often as possible, but it hasn't caused that much of a change. Chondrosarcoma is definitely one area, though, where you do want to get the tract, and you do want to make sure that you mark it if possible.
Very good. I think we have time for one more question. We'll take a question from Dr. Grover in India. What about the postoperative rehabilitation protocol? How do you allow for weight bearing? What is your protocol?
So our protocol is to do a surgery that allows immediate weight bearing. If it means that a joint needs to be replaced, if it means that we have to cement at the surgery site, we do that. The goal is to get them up on their feet, up using their arm as quickly as possible. We do slow down patients a little bit when we put in humeral nails from abducting and forward elevating their arm greater than 90 degrees in the first few weeks, particularly if we have to make a little slit in the rotator cuff at that time. However, we really want them out of bed and moving as quickly as possible, and in general, we get them up on post-op day 1.